Hello, thank you for joining us if you are joining us today, or if you're watching on catch up to listen to our talk, our third talk on premenstrual syndrome, which comes on an amazing day because this is Mental Health Awareness Day. So I will now just invite Dr. Rachel Crystal. Rachel and I both work together at Rowena Health, seeing patients in perimenopause and menopause, and we have set up a chat to talk openly as doctors about how we manage certain conditions, because we think it's really helpful for you in order for you to look. I'm just going to invite Rachel now. How we might manage things. So this is our chat, Two Doctors Talk Menopause, and we have done two previous ones, which you are really welcome to look at on our reel. Hi, Rachel, how are you?
Hi, Carys. I'm really well, thanks. How are you?
Yeah, really good. How has your week been?
My week's been really good, thank you. Yes, I spent the weekend with family. It was my dad's birthday, so my mum organised a big sort of family get together, which was lovely. What about
Yeah,
you?
Yeah, really good. Yes, thank you. Yeah, it was my husband's birthday. So we went out to a really nice local restaurant. So that was actually lovely. And yeah, my daughter came home from university a couple of days beforehand. So it's really nice
Oh,
to have
nice.
some time together, which is really good. So I was explaining that we're doing our chat, Two Doctors Talk Menopause, and that we work together at Rowena Health, and that's where people can find us and book an appointment. And today, the topic that we're going to look at and speak about in more detail is the premenstrual syndromes. So it's not just one, is it? That's
Mm.
when we read more about it, we know that there are a number of different syndromes that we can talk about. So the big question is, what is it? What is PMS?
Yes. And like you say, there's a few sort of different varieties of that, which we can go into, can't we?
Yeah,
But so I suppose premenstrual syndromes are, a collection of physical and emotional symptoms which will occur in the 2 weeks before somebody's period. And then generally they improve once somebody sort of starts their period, and usually have disappeared by the time their period finishes. And some people will have, quite severe PMS, quite severe premenstrual syndromes, and they'll have sort of what we describe as distressing symptoms that affect them physically, affect them behaviorally. They'll have, significant psychological symptoms that happen in that sort of 2 week phase, before the start of their period. And, it's normal for women to experience some symptoms in relation to that time of their month, isn't it?
yeah,
But it's when these symptoms start to have a significant effect on somebody's functioning, and their ability to live their life normally, that we might start to classify that more as severe sort of premenstrual syndrome. And I think around 30% of women have sort of quite moderate to severe PMS, which is obviously having an impact on their quality of life and their functioning. And I suppose, we've previously looked, haven't we, about the hormone cycle, and we can go into that sort of shortly. But the other types of premenstrual syndromes, we have PMDD, which we'll talk about, premenstrual dysphoric dysfunction, but there's also premenstrual exacerbation, isn't there? Do you
yeah,
want to share a little bit about what that
yeah.
is?
It's really interesting, isn't it? So yeah, I was when we're looking at it, so about 30%, between 20 and 40% of women are diagnosed with premenstrual syndrome. So that's those things affecting their quality of life. So, and it was saying, the evidence that I was reading was saying about 80% of us will experience symptoms before our period, but maybe it doesn't really impact on us too much, but for some it will. And maybe between 3 and 8%, so between 3 and 8 women in every 100 of us will develop severe symptoms, PMDD, that will significantly affect the quality of our life. And PME, so premenstrual exacerbation, is when we may have symptoms all month, but they actually get worse from that time from ovulation to the start or during the period. And it tends to be, it's tricky, isn't it, as to, we should probably talk about the symptoms. So the psychological and behavioural symptoms, we can group them into psychological and behavioural and physical symptoms, can't we? And it's not every symptom there are 150 symptoms, which is huge, isn't it? So, and not every person gets the same symptom each month, but it could be that there is a predominant symptom for that particular person, but it can vary a little bit, which is why tracking is so helpful, isn't it? Because we need to know that after ovulation, we see the rise in progesterone, and then if you don't become pregnant, the fall in progesterone just before the period, and that tends to be the time, isn't it? It's after ovulation and the 2 weeks before the period, and maybe even during the period, that can be affected. And some people have symptoms from the whole time. Some people just for a week before. Some people just around ovulation as the progesterone is rising, and then again just before the period as the hormones are dropping. So it doesn't tend to be the same for everyone. And the symptoms, so we can see mood swings. These are really similar to perimenopause, aren't they? We were talking earlier. So I'm going to read them out so I don't miss any, because actually it's quite important. I think we get everything right. So mood swings and depression, tearfulness, which we see as hormones change, feeling very low, feeling tired, fatigued, anxious, out of control. Paranoid thoughts can also come in there. Irritability or agitation, aggression. So we may know that might be when people often will say to women, oh, is it your period? And it will almost become a little bit of a joke that, you're a bit moody, it's your period. But actually with some women, this is really serious. Anger, clumsiness and poor coordination, difficulty concentrating. So doing exams for young girls at that point, we were saying is tricky, isn't it? Sleeping problems, cravings for food, change in sexual desire. And then physical symptoms might be tender breasts, swollen or bloating, puffiness of the face, weight gain, clumsiness, headaches, appetite changes, change in bowel, constipation, diarrhea, as progesterone slows the gut down, joint pains and stiffness, backaches, abdominal cramps. So we're seeing lots and lots of perimenopausal symptoms, aren't we, in the actual physical symptoms and in the behavioural and psychological symptoms. So why does this happen? Why do we know? I don't think we do. There's a number of things that it could be, but we don't really know why, do we?
No. So I suppose one of the main hypotheses is that some people have increased sensitivity to those hormone changes, don't they? So some women seem to be very sensitive to sort of small changes in hormones. And obviously we're having, that luteal phase, that second phase after ovulation and before start of the period. There's lots of things happening with the progesterone. We've got that rise of the progesterone, haven't we? And then sort of the fall, we've got estrogen has fallen quite significantly after ovulation, and then that can also rise again just before ovulation. So there's lots of sort of hormonal changes. So that sensitivity could be one of the reasons. There may be some genetic factors relating to the estrogen receptors, but no one's quite sure. More sort of research is needed in relation to that. I think one thing that we know that it isn't so much is that sort of, there used to be a lot of talk, didn't there, around sort of hormones being out of balance. For younger women, we certainly know more that it's relating to the sort of sensitivity of hormones than a huge sort of problem in terms of the menstrual cycle. And there's also some hypotheses, some people sort of ideas around whether it's related to progesterone itself. And I think, again, more research and information is needed around that, isn't it?
Yeah, I think so. The metabolite of progesterone, the
Mm,
allopregnanolone, has an effect upon the GABA receptors. And for some of us, it makes us feel nice and calm, and it eases low mood and is anti-anxiety. And for others, it has the opposite effect, isn't it? And some people
mm,
are actually quite sensitive to progesterone given to them as part of HRT, and also to the synthetic progestogens that they might have in contraceptive pills or contraceptives. Any sort of all of the hormonal contraceptives all of the hormonal contraceptives will contain either a progestogen, won't they? And another
mm,
thing that they were that the article I was looking at was saying was actually stress. A history of stress and trauma could precipitate these things. And a reaction in the body. So there's a number of hypotheses about why we get it. And we certainly need to know, tracking symptoms is really important because we need to know that it does get better or ease. So the symptoms actually do ease for a certain time of the month, because we need to think, are we actually looking at a mental health problem that's something like generalized anxiety
mm,
disorder or clinical depression? Are we looking at that, or are we looking at a cyclical changes? And because the treatments are different, aren't they, with it? And when we look at how we can ease things using our lifestyle, it's really interesting. So sunshine on the skin can help to make serotonin. Exercise can increase serotonin in the brain. Different types of food. So I'm not going to go into this in detail, but I showed this last time. So remember the tryptophan, we want it to go down to make serotonin. So we want to find foods
mm.
rich in tryptophan that can help to make serotonin, to help our happy hormone. Um, and um, and what about talking therapy?
Yeah.
What effect?
Ye-
How does that come into this?
Yeah, so there's some really good evidence, isn't there, that cognitive behavioral therapy is really useful for managing the emotional changes that come with the premenstrual syndromes. So it's been shown to be as effective as some of
Yeah,
the treatments, antidepressants, for example.
yeah,
And I think this is really useful to know because it helps people who are able to receive sort of CBT, cognitive behavioral therapy, to feel more in control of their emotions, help them feel more in control of the symptoms that they're experiencing, and helps them to sort of manage their experience of their physical, psychological, and emotional changes. And if we think particularly around if somebody's experiencing PMS in perimenopause, we talked last week, didn't we, about the mood changes in perimenopause, and also some of the, we know that cognitive behavioral therapy is also useful for the physical symptoms
yeah.
of perimenopause and menopause, and it just sort of really highlights that link between our thoughts, our body, and how we experience all those changes. So I think that's really, really useful, and you can use that before people try medical or hormonal treatments. You can use it alongside.
Yeah.
So I really think it does have a lot of applicability in that respect, and can be a really useful option, either as something to try early or alongside things, can't it?
Yeah, absolutely. I think I think it's a great skill in life to have, to have. And what if we are going to be trying to balance? So what do we want to do? How can we treat this? If we look at the Royal College of Obs and Gynae
Mm,
guidance, there's some really clear guidance. And what we're going to do is I've written an article for the Rowena Health website, which has got lots of links on it to other websites like the International IA PMD and like the National Association of Premenstrual Syndromes, which have got a lot of amazing information. And so tracking the symptoms is important. So if you're looking for where to find information, that's somewhere that can guide you to the trusted bits of information. And it also guides you to the Royal College of Obstetricians and Gynaecologists, which have got some really good guidance
mm,
in how we can manage this. What comes first? What comes second? and what comes third. And so exercise, CBT, lifestyle changes. And I have seen patients of mine who, for one reason or another, did not want to take hormonal therapy, and they have made significant improvements in their symptoms in that luteal phase using their lifestyle. It's been absolutely amazing to watch what they have done. Now, of course, that won't be the same for everyone, and in severe symptoms, it won't be enough. So what sort of, shall we talk about how we can use antidepressants here? There are three things, aren't there? Antidepressants, low dose and higher dose. Then there's the combined contraceptive pills to try and stop ovulation, stop that fluctuating of hormones. And then we also could look at using hormone replacement therapy in a dose high enough with the estrogen to stop those ovaries from producing the fluctuating levels. So we've got three options for treatment at the top that we probably would be doing in general practice. And then we've got things further down that we probably wouldn't be doing in general practice, things like hormone blockers, and then hysterectomy for some women. So should we talk about why does the antidepressants, why do they work so quickly in PMS, whereas if you're taking them for clinical depression, we say actually, I was reading it could take up to 12 weeks to become effective. So what is it about that? Do we know?
Yeah, no, and I think that's absolutely fascinating. And it's actually, I find it really useful if somebody does get that really quick response in helping us to sort of really confirm that diagnosis as well, because the improvement can be really, really marked, like you say. And we think it's because we're sort of hoping to see changes in different neurotransmitters. So if we're using it for depression, we think we're looking for those improvements in serotonin, aren't we? Yes. Which take time to build up. And it takes time then for that serotonin to have that impact on the brain receptors. When we're using it in PMS, PMDD, we're looking for the changes on the GABA receptors. We're looking for, which then have that calming effect, and that actually happens pretty quickly with using the antidepressants. So that's why we see that very sort of often quick improvement. And one thing that I really like about using antidepressants in this way is that because we get that quick improvement, we can use them at a sort of relatively low dose just in that luteal phase. So just, for example, after ovulation for a couple of weeks until somebody's period arrives and their symptoms are improving, can't we? Yeah. And if somebody isn't sure when they're ovulating, because not everybody is, then we can help them work that out by the length of their cycle and counting 2 weeks before. So that's really a good option sometimes for people who maybe a little bit hesitant about using antidepressants for whatever reason. You can just use them in that second half of the cycle, or some people will just choose to use them throughout the month, won't they?
I've got patients that do both, and actually sometimes it does take a little bit of time for all the symptoms to really work, but I've got young women who've chosen that method, and actually they say it has been life-changing. So really, really helpful for them, and they've made the lifestyle changes as well. And it's meant they can work, their relationships are more secure because they feel well, they can and they don't have those symptoms of the severity of the symptoms. So that's definitely something to consider. What about the combined contraceptive pills? So I love the combined contraceptive pills now, because people sort of, what people may not know is that there are three types of estrogen in the combined contraceptive pill now, aren't there? So there's the ethinyl estradiol, the ones that we have traditionally used for years, since the 60s, I think, when they were introduced, much lower doses now than we used to see. And the combined contraceptive pill has got some really good benefits, and it has disadvantages, which you need to, and contraindications, so it's not for everyone. But there are also the newer ones. Zoli is one with with the same estrogen as we give in HRT. So estradiol, and then we've got a newer one, haven't we? So estetrol, which is in Drovelis. So we've got E4. So we have a number of different options, but the ones that we traditionally use are ethinyl estradiol, and so the combined contraceptive pill contains one of the three types of estrogens and then a progestogen, doesn't it? So that's just a synthetic version of our own progesterone, and there are many different types, aren't there? But the one that they might suggest that we may see better benefit with would be the drospirenone ones, wouldn't it? So the progestogen as a drospirenone one. And we think, so that's going to give a bit more stability. It's going to stop the ovaries, going to stop the production of your own progesterone, because some people don't like that and they get on much better with a synthetic progestogen, don't they? And that then gives that stability. But what about Zoli? What do you think about that?
Yeah, so I think Zoli's really good, particularly in perimenopause. We know that sort of estradiol is a body identical estrogen. So some women tolerate it.
HRT.
Yeah, so some women tolerate that a lot better, for example, than the ethinyl estradiol that's in the older types of pills. So sometimes it can be tolerated much better in that respect. So it's a good option in that. The thing is, if we're using it for PMS symptoms, I would always advise that we use it sort of continuously. So you'd need to not use the 4 dummy tablets.
It comes as a 24 tablets, and then there's 4 sort of placebo tablets. They're not active.
Because the whole reason we're wanting to use the contraceptive pill in perimenopause for PMS is because what we're wanting to do is we're wanting to stop the fluctuations in the natural hormone cycle, aren't we? So we're wanting to sort of turn off that natural cycle, which is what the combined contraceptive pill does, so that then women aren't experiencing those fluctuations, and therefore they're not experiencing that sensitivity to those changes in hormone levels that we think are causing the symptoms. So that's how it works in PMS, and I think Zoli is a great option in perimenopause.
You're also using it a lot more now,
because also then we're getting a bit of that replacement Fanny of symptoms relating to low estrogen, whether that's the mood changes, but joint aches, for example. You're getting sort of a bit of best of both worlds. And for women who can't use the combined contraceptive pill, whether that's because of history of blood clots, for example, or migraine, for example, in which it's contraindicated. I know it's not necessarily so much on the guidance, but I'm finding that some women also can do well, if they need contraception as well. For example, one of the progesterone only pills like Slind, which has got drospirenone in, might be a good option for those women as well.
Have you found that works well? Have you?
I've only used it in a couple of people.
It's really interesting, isn't it? So I think if you've got migraine, so migraine with aura means that you simply can never take the combined contraceptive pill, so we'd have to look at different options, and Slind is one, isn't it? That's a new, very really new one, so we're sort of learning a little bit, aren't we, is how that might work, but that could give that stability of hormones, and sometimes it can be used as part of hormone replacement therapy as well, can't it, as an off-license progestogen. And actually, so because I find in perimenopause, and this is the difficulty I think we have, and we are all seeing this, is when you add HRT in perimenopause, you're adding it to this, aren't you? You're adding extra hormones and you're not giving any stability whatsoever to that woman. You may be improving some symptoms, but others may get worse. So actually, if you are looking at stability, then a type of combined contraceptive pill with one of the 3 estrogens is going to be a good way, or looking at an enough HRT in order to stop the ovulation and stop the fluctuations. So it's a little bit different, isn't it? So when we look at giving HRT for premenstrual syndrome, we added estrogen at a dose to stop ovulation, and that's usually a 100 microgram patch, which now we know is called high dose estrogen, but this is on the guidance from the Royal College of Obs and Gynae, so that we know we can look at that dose in order to try and stop ovulation. It doesn't stop it in everyone, and I think they did a trial with 200
Yes.
micrograms, and they found loads of people got loads of side effects, so they didn't. That's why the guidance has suggested, I think, 100 micrograms, and you can either add in a micronized progesterone on a cyclical basis for maybe a minimum of 12 days a month. We know we need that. Or you can add in a Mirena IUS. And actually, I've got some people who really get on well with the Mirena. They really like it for premenstrual syndrome. It's always a big discussion of, what you're adding in a hormone, how am I going to get on, what's going to happen if I don't get on well with it. And sometimes there may be some side effects initially. And I think the woman needs to know that they can easily come to approach you to have it removed should it not work. But there are a number of different hormonal options, and it's really helpful, I think, to know that if you do have the mood changes, and the mood changes they're virtually the same, aren't they, in perimenopause as PMS PMDD, and if 80% of us get the symptoms, maybe up to 40% of it have it significantly enough to affect our quality of life, and it gets worse as hormones change in perimenopause. We need to know that there are lifestyle things we can do. There are antidepressants that work in a different way that we can either take all month or for part of the month, or just when we have the symptoms. And there are also hormonal treatments to give stability with different types of estrogen and different types of progestogen, because some people really don't like the fluctuations. Some people really don't like progesterone. Some people really don't like the synthetic progestogens, but there's definitely not a one size fits all. And there's usually something that we can find, isn't there, that will suit that person really well, but it sometimes can take a little bit of trial and error. What about supplements?
Yeah.
We were talking about them as well. Is there
Yeah.
much evidence for other things?
There's there's some evidence, isn't there? And I suppose actually I find it really positive. I don't know about you, but I actually find it really positive that we have got some medical guidelines that are actually talking about supplementation, and there is some evidence for it, because we don't have that in a lot of other conditions, do we?
No.
So I think this is really positive. I think there is some evidence, isn't there, for magnesium, supplementing magnesium. Doesn't go into detail about which type of magnesium is best, and there isn't a great deal of information around dosing, but there is some evidence that is helpful. So I do always, recommend that to people who are interested in taking supplements. It's something that's, if people can tolerate it, okay, then it's unlikely to do any harm, isn't it? From what we know. And then there's also some evidence, and this is particularly true, I believe, for women who experience hormonal migraine as well. So it's sort of two birds, one stone. But sort of calcium and vitamin D can be useful, can't it?
Does it state,
and then
sorry to interrupt you, does it state whether we should have it in our diet or we should have vitamin D? There's so much controversy, isn't there? So calcium's usually dietary, isn't it?
Yes.
And then vitamin D.
But I believe the trial that was done looking at the calcium and vitamin D was done based on supplementation. So that's the evidence that we have, and that's what the NAPS guideline sort of suggests, tentatively talk about there being a small amount of evidence for that. I do think, to recommend that on a wide scale basis, we probably need bigger trials, don't we? But I find that can be a useful thing that people are quite happy to try usually.
I wonder why that is. Why is that? I don't know. I haven't read any evidence of why calcium and vitamin. I can see vitamin D, because we know, if we're looking at this here, we know that we need enough vitamin D, iron, zinc, magnesium, vitamin B6. Vitamin B6 is another one, isn't it? So that's something where we can recommend on an individual basis, but we don't want to take too much of it because it can cause neurological problems. So we have to take care with that. So I think when you're looking at diet to really look at your mood, it's really important to get all the essential nutrients included. I quite often now see women's blood tests who are vitamin D deficient,
Mm.
folate deficient, and not necessarily vitamin B12, but often low in iron.
Yeah.
And actually, that happens quite commonly for me in GP now,
Mm.
and in perimenopausal women. When I speak about what they actually eat, I don't think their diet is wide and varied enough to support their mental health. So we talk about it, and we talk about gut health, which we now know is really important, isn't it? So I think what's so interesting, it's that time of life, isn't it, where maybe you've got little children and you're eating what they are eating, which might be what they like, and not necessarily going to feed your body with what it needs at that stage of life. Do you have the
Yeah,
same thing?
definitely. And I see, so many we know that we don't necessarily always need blood tests to diagnose
Yeah,
menopause and perimenopause, but we often like to do other blood tests to see if there could be underlying causes or other things that
yeah.
need treatment. And it's so common. I mean, certainly the area that I work in, we actually can't test for vitamin D, because they work on the assumption that
Everyone's
everybody is low.
deficient.
But certainly, sort of
Yeah,
private blood tests that are doing everybody's
yeah,
low in vitamin D, and
yeah,
there's an awful lot of borderline low folate levels,
yeah,
and low ferritin, and obviously that can be due to heavy periods and things. But
yeah.
culturally as a society, our diet,
Isn't giving us
generally,
what we need.
no.
Yeah,
And I think perhaps there's more people as well who are vegetarian, vegan,
yeah,
and then also because of the weight gain that can often occur in perimenopause or as people get older, there's a trend towards fasting, isn't there?
yes.
And
I'm
I think
seeing
if
it.
you're
Yeah,
intermittent fasting, you're eating fewer meals, it's harder to get that range, it's harder to get the nutrients that you need. So if fasting works for you, then great. But really, really important to make sure you're getting that variety of
love that.
nutrients for your gut,
Yeah,
for your microbiome. It's so important for how it impacts our hormones, our mental health,
yeah,
not the neurotransmitters. And we were also talking earlier, weren't we, about how those hormonal changes in the luteal phase, the second phase of the
yeah,
cycle, we actually need more complex carbohydrates,
yeah.
don't we? Our bodies find it harder to sort of, this is a very simplistic description, but to give the sort of get the glucose to the brain is much harder
Yeah, no, that's
for the body.
perfect.
So if we're having, if we're not eating much, or we're not eating many carbohydrates, because we're trying to lose weight, or because just to try and maintain weight, or we're fasting,
Mhm.
then it's no wonder that we're going to be irritable. It's no wonder that we're going to be low in mood, anxious, because actually we need to fuel our bodies, particularly in that second half of the month. And if you add in in lots of cardio or extreme exercise to that, lots of levels of stress, it's no wonder that it's going to be harder for our mood to stay the way that we
That's
feel
so right.
good. So there's so
Absolutely.
much to this, isn't there?
Huge
um
amounts. And I think now I am seeing people who are really restricting to try and lose weight. And
mm,
actually, what's happening is that symptoms are starting. So they may start to get night sweats back because their blood
mm,
sugar is low and their
yeah.
cortisol is increasing, and is waking them up. So I think fueling your body, being kind to yourself, resting while you've got these symptoms is really important. But knowing that there are lots of things there to do. I think we've done a brilliant job. Thank you.
Yeah,
It's
we've
whizzed by. We've
we've
done we've
covered a
done
lot, haven't
really
we?
we have done really, really well. Thank you. And I think we should just finish by saying some people
Mm,
feel really mentally very unwell when they have with their menstrual cycle, and they may feel suicidal, and some people even have attempted suicide with this. It's not
mm,
uncommon. So, if this is happening to you and you do want to seek medical advice, then if you go speak to your GP, and go and you can speak to the Samaritans. But if you're in a crisis, then going to accident emergency or calling 999. But what's really helpful is that you know your crisis numbers and they are on your phone as a saved number, and that your family members also know them, so that if you really are having a low day, that actually you don't have to search around for a number, you have it there with easy access. So thank you, Rachel. I think that was brilliant, and I think really, hopefully really helpful. Thank you everyone for listening. And we will save this to our grids.
Yes,
so
and
that
Carys, will you share the brilliant article that you've written that's got all the resources on for
Yeah,
people?
absolutely. Yeah, I'll put it. So it's on our Rowena Health website. We've got lots of articles, and it's the most recent one. And it just summarizes information taken from the really good websites. And also at the bottom has links to lots of websites for you to look at. So you can track your symptoms, so we can make a really good diagnosis. And then we know, and then once we have the diagnosis and that information, then we can really helpfully look at what treatment options might be best for you.
Oh, thank you so much. Yeah, I think it's a really useful article that's got all the links as well, like you say. So really good one to have a look at. And I suppose, like our previous videos, I think we just want to highlight that this is general advice. Some of it may not be appropriate or suitable for anyone who's watching and their individual medical needs. So please do speak to your own GP if you're concerned, or you want more information about sort of treatment options as well. I think just want to highlight that. And if you've had a look at the article as well, that can help you be even more prepared for your appointment with your GP, can't it, Carys?
Yeah, absolutely. Well, it's lovely to see you, and
yeah, you too.
And have a lovely week, and thanks everyone for listening.
Take care. Bye-bye.
Bye.